Good evening and welcome to our special town hall event, Living with COVID-19. What's next? I am Mary Croughan, Provost and Executive Vice Chancellor of UC Davis. I am grateful to be serving as a moderator for our discussion this evening. This event has been organized in collaboration between UC Davis, Healthy Davis, and Healthy Yolo together, and the Yolo County Department of Public Health. Our aim tonight is to host an open discussion on the current status of the pandemic, as some mandates are reduced to recommendations and as cases decline. As such, we want to discuss what the future of COVID-19 might look like for our community. We have brought together 3 health experts to answer your questions about what the science currently tells us and what to expect in the weeks and months ahead. We will start by addressing questions and have gathered in advance from the community, and then we will turn to questions from you as our audience. If you are participating on Zoom, please submit your questions in the Zoom question box. If you are watching on Facebook or YouTube, please write your questions in the comments section. I will pose as many of your questions to our panel as possible. And with that, I would like to welcome our 3 panelists. Dr. Aimee Sisson has served as the Yolo County Public Health Officer since October 2020. Before that, she worked at the California Department of Public Health for 10 years and served as a health officer of Placer County for 1 year. She is an expert in public health with an MD from UCLA and a master's of public health from UC Davis. Our next panelist is Dr. Sheri Belafsky, who serves as the medical director of the Healthy Davis Together initiative, as well as the director of the UC Davis Medical Surveillance Program. She is a physician in occupational and environmental medicine with both an MS in public health science and policy from UC Irvine and an MD from the Tulane University School of Medicine. Our third panelist is Dr. Cindy Schorzman, who serves as the medical director of student health and counseling services at UC Davis. She has been in the medical field for over 20 years, specializing in adolescent medicine, women's health, and LGBTQ health. She has an MD from the University of Arizona College of Medicine. I will also contribute to the discussion as needed as UC Davis Provost and also as an epidemiologist, where I spent 30 years on the faculty of the UC San Francisco School of Medicine. Welcome to you all.
Thank you.
Now let's get started. Dr. Sisson, Yolo County revised its COVID-19 guidance, including indoor mask mandates and testing requirements in certain scenarios. Can you explain what changes are being made and why the county is making them at this point?
Yeah, happy to. We've had 2 recent changes. The latest will go into effect tomorrow, but particularly in the area of masking. So what you're seeing is a shift away from requirements issued by government entities and a movement towards recommendations, in this case, strong recommendations. So on February 16th, the state moved away from requiring fully vaccinated people to wear masks in all indoor spaces. And so Yolo County aligned with the state in making that move on February 16th. And the state announced today that they will no longer require unvaccinated people to mask indoors in most indoor settings. And so Yolo County sent a press release out earlier today indicating that we will align with the state in that change as well. So still strongly recommending that everybody wears masks indoors, but moving to a place where it's an individual decision made based on somebody's individual risk factors and not a government mandate.
Great, thank you. And Dr. Schorzman, the changes from the county have implications on what happens on campus here. What health policy changes are being made at UC Davis as we enter this new stage in the pandemic?
They absolutely do. Thank you for asking. As we have since the start of the pandemic, we at UC Davis are conferring with our own infectious disease and other local experts, of course, our awesome county colleagues and our amazing staff here on campus in the context of local and state and national guidelines. At this time, we plan to continue the indoor mask mandate here on campus for at least the next 3 weeks through the end of winter quarter. That gives us some space and time to really assess our next steps for spring. In addition, you may very well be aware that we are increasing testing for certain people in our population. Right now, we're testing everybody who is not fully vaccinated every 4 days, and we're really helping to move those individuals who are not up to date with their vaccines, including not meeting the booster mandate. Those individuals will start to be asked to test every 4 days as well as of March 28th.
Great, thank you. So we've seen a lot of questions come in about masking, and in the last few days, the CDC announced a new masking recommendation system based on the level of community spread of the virus and its impact on hospitals. Dr. Sisson, can you explain the CDC's new masking system and how Yolo County is updating its masking policies, especially with regard to masking in public schools?
Yeah, this is somewhat complicated, and I will predicate it by saying that the CDC just made these changes on Friday, and the state of California is still determining how they will adjust their masking policies. CDC makes recommendations, but the California Department of Public Health essentially issues requirements that we have to follow in California. So Yolo County is aligned with the state, which right now is not aligned with the CDC. So Yolo County will continue to align with the state. But essentially what the CDC did was move away from a metric that they called community transmission, which was based solely on case rates and testing positivity, towards something that they're calling COVID-19 community levels, which take into account not just cases, but also how burdened our healthcare system is by those cases. So it's also taking into account regional hospitalizations, new hospitalizations for COVID-19, as well as the proportion of hospital beds that are occupied by people with COVID-19. And so right now that metric for Yolo County falls into the middle of the 3 new categories, medium. So we have low, medium, and high. If we were following CDC recommendations, that would mean that masking would not be recommended for everybody in the medium tier. However, we're still aligned with the state, and so we've moved away from requiring masking, but still strongly recommending masking for everybody. Now, schools is a different story. I talked earlier about masking being strongly recommended, but not required in most indoor settings in California, including Yolo County. Schools, however, are one of the few settings in which everybody has to wear a mask regardless of their vaccination status, and it's a requirement. The state announced today that beginning March 12th, students and teachers on K through 12 campuses, as well as childcare settings, will no longer be required to wear masks. So we'll be moving again from a requirement to a strong recommendation for schools on March 12th.
Hey, thank you. I know it's complicated, but that was a very clear description of it. So thank you. Dr. Schorzman, can you speak to why we are still asking our UC Davis community to stay masked indoors and whether new masking guidelines may affect these policies?
Absolutely. Thank you for asking. As you mentioned, it is complicated, and we are absolutely taking the lead from our local public health experts. Right now, we have multiple factors to consider. I mean, on this big of a campus, we have spaces, including academic spaces, in which physical distancing just can't happen. We have congregate residential housing, and we couple that with the change fatigue that we've noticed over the past 2 years of the pandemic, and also the very real fears people have, some people have about discontinuing masking indoors. So there's really a complex issue here on campus, and we have had so much thrown at us over the last 2 years where we've had to change on a dime, where we've like, this has to happen tomorrow, this has to happen immediately. And we have not, in a lot of instances, been able to give people the time and the space to process these changes. So what our campus leadership doing is really taking a thoughtful look, continuing status quo for now, and really giving everybody a chance to breathe and really look at what this means for campus, and make sure that we're listening and getting all the opinions, and letting everyone really voice their opinion, and making any changes thoughtfully and with appropriate consideration and communication.
Well, as one of those campus leaders, I appreciate your description there. We have worked very hard to try to meet both the needs of people and address their fears and concerns while simultaneously doing our best to keep everyone healthy. And we've greatly appreciated that partnership with the county and with your office as well, Dr. Schorzman. So thank you all. So Dr. Sisson, this question is for you. With at-home rapid antigen tests now more widely available, can you explain the difference between antigen and PCR tests and why someone should choose to take one test over the other?
Yeah, I would say there's two major differences aside from the technology itself. One is looking at the RNA of the virus, and that's PCR. The other is looking at an antigen, a protein on the surface of the virus itself. That's the antigen test. But for practical terms, there's really two differences. One is how accurate the test result is, how confident you can be in either a positive or a negative result. And then the second is how quickly do you need an answer. Rapid antigen tests are called rapid antigen tests because they provide an answer in as little as 10 minutes, depending on the test that you're using. But there's a trade-off for that speed, and that trade-off is in its ability to detect somebody who's positive. So if somebody gets a positive result on an antigen test, they can be very confident that that result is true. There's no need to confirm it with PCR. But if somebody gets a negative result on an antigen test, there's a possibility that that might be a false negative. And so we usually want them to test again in a couple of days. So you're trading off that very rapid result for the possibility that you may miss some people who are positive. So those are the two biggest differences between PCR testing and antigen testing.
Great, thank you very much. Dr. Belafsky, for you. Healthy Davis and Healthy Yolo together are planning to continue to offer free PCR testing to residents of Yolo County through June. What will their role look like after June?
Thank you, Provost. Well, so a big part of Healthy Davis obviously has been testing, but we've also been very involved in knowledge sharing, both with our partners at the county and the city of Davis. And we continue to meet with both those groups and share our monitoring data to kind of help inform their decision-making and their planning and preparedness. And we'll continue to do that through June. And then following June, we will continue with our wastewater monitoring program. That's again done in partnership with the city of Davis and Yolo County, and that will continue through January of 2023.
Great, thank you very much. And another question for you, Dr. Belafsky. We have some parents who are asking if COVID-19 is less severe in children, and if so, why do they still need to get vaccinated? And especially if they've already had COVID, do they still need to get vaccinated?
Right, what a great question. And the answer is yes, absolutely. They still need to get vaccinated, even if they've been infected before, and for good reasons. And one is that children are as likely as adults to become infected with COVID if they're exposed, and that they can become very ill as well, like adults can. They can have short-term and long-term complications, and they can spread COVID to others. So it is really critical that they do get vaccinated. And vaccines, as we know, are very safe both in adults and children. And that last point would also be that we know that even if adults or children have had a prior infection, that their immunity is very much enhanced by having a vaccine following infection.
Wonderful, thank you. A lot of people know this from previous COVID talks, but I myself was infected with COVID in March of 2020, very early in the pandemic, after flying on an airplane next to someone who turned out to be very sick, returning from Italy as an exchange student. That was a Wednesday evening. By Friday evening, my symptoms started, and 3.5 weeks later, I basically became relatively conscious again and back in this world. So 3.5 weeks of sleeping 20 hours out of every 24. Even with that significant of an infection, I still received 2 vaccines and a booster. So I just want to use that as an example about the importance of vaccination, even for people who've been previously infected. I think it's really critical. So thank you for addressing that as well. Dr. Sisson, we're hearing about a new subvariant of the Omicron strain of SARS-CoV-2 known as BA.2 or BA2, the virus that causes COVID-19. Can you tell us what we know about this variant?
Yeah, we're still learning about BA.2, but it is a subvariant of Omicron. We refer to the original Omicron as BA.1, but these 2 versions, BA.1, BA.2, actually emerged at the same time. So BA.2 has been around as long as BA.1. We're just hearing about it because it's growing. And it's growing because it's actually more infectious than BA.1. It's thought to be between 30% and 50% more contagious than BA.1. The good news is that our vaccines appear to work just as well, if not better, against BA.2 than they do against BA.1. And BA.2 has not been shown in the real world to cause more severe disease, although there were some studies that were posted recently suggesting concern about increased severity of disease in hamsters, but that has not borne out in the real world data coming from other countries. At this point, the Genome Center at UC Davis is tracking the proportion of cases in Yolo County that are caused by the BA.2 subvariant. It has been growing, particularly on the UC Davis campus. We're up to 20% of cases in the whole community, but being caused by BA.2. So we're watching this closely, but again, it's not associated with more severe disease, but it is associated with increased infectiousness. But as we've been seeing the proportion of cases caused by BA.2 increasing, we have not seen any increases in our case rate. So that's reassuring. Our case rate continues to decrease from its all-time high of 244 on January 9th down to 21 today.
Which is great news for all of us. And Dr. Schorzman, how is the university assessing the safety of reducing on-campus pandemic restrictions and bringing daily life somewhat back to normal? Is it if a new variant arises, will additional restrictions be implemented?
Yes, thank you for asking. So we are continuing to monitor the numbers very closely. So we're continuing our robust asymptomatic testing on campus, and just like we are, you can follow our numbers on the dashboard on our Campus Ready website. So we're keeping a close eye on those as we make any changes. We're also continuing our symptomatic testing for students here at Student Health and Counseling Center. So we're watching those numbers as well. But beyond the numbers, we're really talking with people, and we're continuing to really listen and assess and see what questions are out there, what concerns are out there, so we can continue to pivot. We continue to address those concerns. And our campus community has been incredibly resilient and incredibly flexible. It's just been amazing. And I am absolutely positive that if and when a new variant arises, we are up to meet that new challenge. And we'll change as we need to, just as we have for the last 2 years.
I completely agree. I hope we don't need to do it again, but we're ready if needed. And another question for you, Dr. Schorzman. Many of the resources that have made the Davis and Yolo County pandemic responses so successful have come out of UC Davis, including our widespread testing infrastructure, staffing for clinics, and public health education. Do you feel these efforts will inspire similar future work or change the university's relationship with the community in the long term?
Oh, I have no doubt. We were privileged to stand up the first testing kiosk. We provided a framework, and HDT took that and ran with the ball and just multiplied that success by leaps and bounds throughout our community. It's been an amazing partnership, and the pandemic's been hard, but one of the very bright spots has been getting to work with people and collaborate with people, all of us working way outside of our comfort zones to protect our community, including webinars. And I don't see us ever going back to silos. I think we're only going to get stronger together and continue to build on those partnerships.
Thank you. And I can add to that from personal experience. I served as co-chair of the advisory committee for Healthy Davis Together, along with Mike Webb, the City of Davis city manager. And having a university and city partnership in that effort made a massive difference, not just in relationship to the pandemic, but it's gone far beyond that in our collaborations and other activities as well. So, and a silver lining of the pandemic are the really wonderful town gown relationships that we have. So this next question is for all of you, and I'll start by having Dr. Belafsky respond, then Dr. Sisson, and then Dr. Schorzman. So public health experts around the country are suggesting that COVID-19 may become an endemic virus. I present that to people as being very much like influenza or flu. What do you think that means, and how might our response to the virus change in that case? So Dr. Belafsky.
Right. So I think we all need some good news, and focusing on when COVID becomes endemic seems like a good thing. So I'll lean on what Dr. Schorzman said a moment ago. I think when I consider that state of when COVID is really endemic, that it's going to require flexibility, right? It's because it's how we get there, right? We're in a lovely window right now of having cases falling, right? So it's easy to say pandemic's over, but we're trying to be flexible in this moment and be aware that could change at any time. So flexibility and being able to put a mask back on, being able to stay aware and accountable. What is my county's case rate, right? What the CDC presented to us, our new low, medium, and high community levels. That's going to be our responsibility to be keeping pace with that and paying attention to that. So as I think we become more comfortable with taking personal accountability and moving away from the mandates that Dr. Sisson mentioned, I think we're going to personally keep an eye on what community levels are doing, and we're going to need to be ready to pivot and take greater precautions as needed.
Wonderful, thank you. So Dr. Sisson, what do you think it means if this becomes an endemic rather than pandemic situation, and how might our response change?
Yeah, I actually don't like to use the term endemic. There was a great piece in The Atlantic a few weeks ago where the author spoke with multiple epidemiologists and experts and asked them to define endemic, and they all gave a very different answer. So I don't find it that helpful to frame the next phase of COVID around a word that even the experts can't agree on what it means. But I do like to talk about learning to live with COVID, and I think that's what's coming. And you can already see in the change in both the state and the county's response with masking in particular, that we're entering that next phase of learning to live with COVID. And for me, part of that is, as I already discussed, a shift away from government mandates, orders, and directives from the health officer at the county or at the state level, and towards recommendations. Public health typically exists in the world of recommendations and guidance and educating individuals on how to protect themselves. And I think that's what we're going to see more of in this next phase of learning to live with COVID. I also think we're going to do different ways of keeping an eye on what's happening with COVID in our community. So right now we talk a lot about case rates and testing positivity and hospitalizations. As we move into this new phase and those numbers are lower, we're still going to want to be able to keep good eyes on what's happening with the virus. And so you're going to see a shift away from PCR testing of saliva specimens or anterior nasal specimens and more towards wastewater surveillance. So I think that is also part of this next phase of learning to live with COVID, is talking about different metrics than we're used to hearing about over the last 2 years.
Great. And Dr. Schorzman, anything you wanted to add?
My colleagues have made absolutely incredible points. So not too much to add other than really just focusing on, as Sheri mentioned, that flexibility, retaining the institutional knowledge. And we've learned so much over the last 2 years, making sure we're recording everything, writing everything down, and keeping a base framework of people who really have internalized that and know what they're doing. And when we get those early warning signs from wastewater and stuff, being ready to stand back up and retaining that ability to scale up and scale down as appropriate.
Great, thank you. So we'll now open it up to questions that have been shared in the chat. A reminder to our audience who are watching live, you can post questions using the Zoom question box or in the comments of Facebook or YouTube. Our team is monitoring, and I will do my best to fit in as many questions as possible. So let me go to the first question here. There was recent news about the Pfizer COVID vaccine being significantly less effective in kids between 5 to 11 years of age. What is being done to increase protection for kids in this age group? Will they be eligible for boosters? Are other vaccine makers applying for emergency approval, or that would be emergency use authorization for the correct term there, for this age group that might have more effective products? And I think I'll start with Dr. Sisson and then see if either of our other two guests have an additional response.
Sure. This question, the basis was reported out in the New York Times today, and it's based on data from New York State. We haven't seen the national data about effectiveness of vaccination in preventing infection and hospitalization in children ages 5 to 11. So I think we're waiting for more information to see if the findings in New York are confirmed nationwide. It would be concerning, particularly if we're seeing a decrease in the effectiveness of vaccination to prevent hospitalization. We already know, we've seen in adults, particularly with the Omicron variant, that we have breakthrough infections. There's many people who are vaccinated and even people who are boosted who have still been infected with Omicron, because that's how infectious it is, and also because it evades immunity. But what we don't know the hospitalization data appears to be relatively preserved in children with the Pfizer vaccine in the New York data. And that's what we're most interested in. We know with these very infectious variants that we may see breakthrough infections. But what we really want is protection against severe disease, hospitalization, and death. And at least the New York data suggests that continues even with decreased effectiveness against infection. But of course, states And local governments, states, and the federal government continue to look at the data that's coming in. I know the pharmaceutical companies are evaluating whether boosters will be needed in the 5 to 11 age group. So we will continue to follow that. But at this time, I'm not aware of any applications for booster authorization in younger kids.
Great. And Dr. Belafsky, was there anything you wanted to add to that?
Just that for other vaccines that might be in the pipeline for kids, that Moderna is still in trials, but that should be hopefully available for kids as well.
Okay. And Dr. Schorzman, anything else that you wanted to add?
Nothing to add. Thank you.
Great. You're all being very thorough, which is greatly appreciated here. So our next question, and this is, I think, also best answered, at least initially, by Dr. Sisson. To what degree do the COVID statistics in Sacramento County influence the policies here in Davis?
Yeah, in general, they don't. As Yolo County Health Officer, I'm making decisions based on the data here in Yolo County. That being said, I'm in regular communication with all the health officers in the region, including Sacramento County, and I do pay attention to what's happening in the overall region. In general, we trend together, although Yolo County has, throughout the pandemic, had a lower testing positivity rate than our neighbors. But right now, our case rates are in the greater Sacramento region are trending together and also trending with the state. But I am making decisions as the Yolo County Health Officer based on data from Yolo County.
Great, thank you. This next question is listed as a personal question to each of us, but I would say you could pass if you want to, but I'll begin with my own response to it. And the question is this: will you personally still be wearing your mask when going shopping or inside at public places? I can tell you that I personally wear a mask every time I'm indoors. I will take it off in a restaurant once the food or drink service has been provided. But I will wear it continually from the time I leave my car until I'm back to my car, if it's something like grocery shopping or things like that. And regularly on campus, it actually feels very strange if you don't have a mask on, even when you're outdoors, because our students are phenomenally good about wearing their masks. So for me personally, I'd say I wear a mask about 90% of the time. So, Dr. Belafsky, I'll let you answer next or pass as you so choose.
I am wearing a mask indoors. Absolutely, it feels most comfortable while our case rate is what it is. I'm waiting for us to drop down into the low transmission level, and that'll, I think, give me that peace of mind. But until then, indoors, I'm absolutely wearing a mask.
Great. And Dr. Schorzman?
Yeah, I have absolutely the same answer. I feel weird without mine now, and I wear it all over campus from the time I get out of my car to the time I get back in, unless I'm in a private office, and I plan on continuing wearing my mask in all indoor spaces unless actively eating or drinking.
Great. And Dr. Sisson?
Yeah, I continue to wear either a KN95 or a KF94 mask indoors in all public spaces. And, you know, the health officer of Yolo County continues to strongly recommend that everybody, regardless of their vaccination status, wears a mask indoors. And I have to follow my own recommendation. So as long as I'm strongly recommending other people to wear a mask, I will continue to wear a mask. And I will wear the highest quality mask that I have available to me that fits me well, so that I can tolerate wearing it for extended periods of time.
And interestingly, this is exactly the next question. So I'm going to consider you to have already answered it. And it was whether the N95 or KN95 masks were still being recommended. I'm going to take that as a yes. Certainly still what we're recommending on campus here too. A quick aside, I was visiting friends up in Trinity County, where I must say they do not act the way they do here in Yolo County with wearing masks regularly. And in leaving the restaurant, I put my mask back on the second I stood up from the table. And almost in chorus, everyone in the restaurant made a comment about me putting a mask on. And I turned around, this restaurant held about 40 people. And I said, as an epidemiologist, this is the safest approach for me to use. And then I walked out of the restaurant and I thought of all the things to say to me. Yes, I will wear my mask. Absolutely. So.
Provost Croughan,
So the next,
if I
yes.
may, I just wanted to say one of the things that we're trying to emphasize as we move away from requirements into recommendations is respect for individuals' choices. In the Yolo County situation, it could go either way. We could have a setting in which some people, the majority of people are masked and a few people are not, and we should respect that. We should also respect the reverse situation where the reverse situation. So I just want to make sure that we do not bully those who make a different mask choice than us based on their personal circumstances.
Agreed, very much. Next question. I'm going to pose this to all three of you because I must admit this has a little bit of a crystal ball aspect to it. So when will we be able to get the next booster since the efficacy of boosters declines over time? I'll turn to Dr. Schorzman first.
Sure. It's hard to tell. I know that they've done so many studies, and really the evidence so far has not been overwhelming that the fourth dose is really more efficacious at preventing especially severe disease, hospitalization, and death. So initially we all thought, many of us thought we'd be getting boosters again 6 months after our last one, but the data so far hasn't really panned out like we thought it might. So I'm still anticipating that there will be boosters down the line, especially as new variants come and as they reformulate the medication, but I don't think it's going to be the 6-month booster that everyone was anticipating.
And Dr. Belafsky?
I agree with Dr. Schorzman. From what I've been reading as well, all signs point to we get a break. We don't need another booster at 6 months again. It may be more at the year mark from what I've been reading, and to kind of align with what we do for, say, flu. So that would be, at this point, my expectation.
And Dr. Sisson, anything to add?
The one thing I'll add is, well, I don't think we're going to see a second booster recommended anytime soon for the general population, but I do think some of the studies are beginning to see some evidence of waning protection against severe disease in older adults, so particularly 65 and older, and those who are immunocompromised. So I think you may see a recommendation for an additional booster in that population, but for the 12 to 65, that protection seems to be durable, and I don't think you're going to see a recommendation anytime soon for a second booster.
Great, thank you very much. Dr. Schorzman, I'd say this question is for you and possibly for me, but will asymptomatic testing for students and employees also end in June, or just the free community testing offered through HDT?
The short answer is we don't know yet. We're too far away from June to make that answer. We've certainly committed to having testing resources widely available on campus through June. And we're willing to stick it out as long as it takes as far as the testing program goes. There's so many variables that will go into that I can't predict whether or not it'll continue past June at this point.
I would completely agree with that response too. So I'm also going to, given this is a campus-specific question, again, I'll direct it to you, Dr. Schorzman. When can we expect to stop having to do testing and the daily symptom survey?
Again, not right now. We're actually really happy with our testing program. We've made it quick and efficient, and I think the numbers bear out that we've kept our rates on campus lower than the surrounding community, which has been lower than the state. And we aren't in a big hurry to end the testing program. That being said, we want to follow the science. So we're definitely looking at, at every 14 days for up-to-date individuals who have gotten their vaccine and their booster. Right now, when we're testing every 14 days, we're kind of doing a random sampling. And whether it makes sense to continue that indefinitely, I don't know. So we're really looking at that population and at the data, and we'll do what makes sense based on the science.
Great, thank you. Will free testing end after June for Healthy Davis Together? And I'll pose that to you, Dr. Belafsky.
So my answer is sadly yes. We will end our saliva testing program at the end of June, but there's good news. And that is, while testing will still be important for people who have symptoms or exposed, I think that the county resources will be sufficient. And I think we'll have, as we're already seeing, free rapid tests have been available, both at the federal level and then other local resources. You can go to a pharmacy for PCR testing, or go to a pharmacy for a free home kit. And then the county has OptumServe. There are, and of course, I don't want to underestimate our personal healthcare providers as well as a great source for testing for that group. But yes, that will be the end of HDT's saliva testing.
Okay. It's funny, the questions just keep coming, even though I think they're about to end. Where do we stand with availability of COVID-19 treatments if needed? And I'll pass that to Dr. Sisson.
Yeah, good news here is that the number of treatments available is increasing. And in terms of we have an additional monoclonal antibody for treatment, bebtelovimab, that's been added to sotrovimab. So we now have 2 monoclonal antibodies that can be used in people with moderate illness to prevent them from progressing to severe disease and needing hospitalization. So that's essentially a doubling of the supply of monoclonal antibodies by adding the bebtelovimab. We also now have available locally in Yolo County what was only available regionally before, a pre-exposure prophylaxis monoclonal antibody called Evosheld. This is an injection that's given to people with moderate to severe illness, moderate to severe immunocompromised, that lasts for 6 to 9 months to prevent them from getting infected in the first place. So this is a great resource to have to prevent infection in those who are least likely to have an adequate response to vaccination. And then we have oral antivirals, in particular Paxlovid, which is manufactured by Pfizer, which is 90% effective when taken within 5 days of symptoms in preventing someone from becoming hospitalized. We recently doubled the number of courses that we were being allocated by the state. Previously, we'd been getting 10 or 20 courses every week and a half to 2 weeks from the state of Paxlovid. In our last allocation, we received 40 courses and we were able to onboard a new pharmacy. So we now have a pharmacy in Woodland, a pharmacy in Davis, and a pharmacy in West Sacramento. And we're also adding CommuniCare health centers that will be able to provide Paxlovid, which is an oral antiviral, to those who have tested positive. So we have more options and more numbers of courses available than we ever have. And that's part of why we feel comfortable slowly relaxing our restrictions, because in addition to effective vaccinations, we have effective and more widely available treatments.
Wonderful. It's good news for us all. I'll probably pose this starting with Dr. Sisson and then ask our other two physicians here for their insights. Any practical advice for parents with kids under 5 who are ineligible for vaccination? Also, what if they have older siblings in school where mask mandates have been eased? So, Dr. Sisson?
Yeah, until our youngest kids, those under 5, are able to be vaccinated, the best way to protect them is to have those around them be vaccinated. So anyone in their life who's over the age of 5 who is eligible to be vaccinated should get vaccinated. So that protects kids under 5. The next piece is masking in public settings for those who are 2 or older. We don't recommend masking for anyone under the age of 2, but certainly children 2 to 5 are able to wear masks in public spaces. So they won't be required moving forward, but we continue to strongly recommend them for those who aren't eligible to be vaccinated. So in addition, I think minimizing exposure as much as possible. So if you're a single parent, for example, and you typically would take your unvaccinated child to the grocery store with you because you don't want to hire a babysitter for that experience, I would recommend exploring non-contact options like free grocery delivery, so that you don't have to expose your unvaccinated child to unmasked individuals. We're hoping that in April or so, we will get updated data from Pfizer on the 3rd dose of their vaccine trial for children under 5, and that hopefully sometime in April, you'll see an emergency use authorization for our youngest kids. So we only, I think the parents of those under 5 will be relieved to know that we're only going to be in this situation of their children not being eligible to get vaccinated for another month or 2. So I know it's hard right now, but there are ways to protect your unvaccinated child.
Great. And Dr. Schorzman, is there anything you wanted to add to that?
For me, the only thing I would add is that adds into the personal equation when you're thinking about whether or not you're going to wear a mask. We talked about, the personal decision making when you're going into public indoor space. And certainly if I'm going to be around a younger than 5 person or anyone who's at increased risk for severe disease or contracting the disease, that's going to make me think additionally about my own personal responsibility to try and keep them safe and wearing a mask.
Wonderful. And Dr. Belafsky, anything you want to add?
Always the testing side. Yes, I've seen a really great response locally at our preschools, where they have immediately notified whole cohorts, classes, and asked parents to test whenever there's been a case detected. So I would say that's another great tool that parents can utilize.
Wonderful. Thank you. I'll start with Dr. Schorzman with this question and then ask the other two of you to respond as well. What advice do you have at this point for the population of immunocompromised people?
So following the non-pharmaceutical interventions, especially a well-fitting mask like an KN95 if you're going out in public, and really having that good discussion with your healthcare provider. Does a 4th dose of vaccine make sense for me, even though it's not recommended necessarily for the general population, being a booster 6 months after my last booster. If I get sick, or if I'm exposed, are there additional steps that you'd recommend? Because as Dr. Sisson mentioned, there's the pre-exposure prophylaxis potential option for them, or if they know they were exposed and they start to get sick, they would be very good candidates for some of the therapies that are available. So ahead of getting into that situation at 2 a.m. on a Sunday, really having that heart-to-heart discussion with their provider, knowing what their options are now, knowing what they recommend, and knowing what their options are if they do get sick.
Great. Dr. Belafsky, anything you wanted to add?
I would add that that conversation that Dr. Schorzman just mentioned is very important with family members or close friends, and that if there's a desire to gather, that they carefully discuss risk, and there may be an opportunity to use rapid tests prior to gathering.
Wonderful. And Dr. Sisson?
I'll just reiterate Dr. Schorzman's points, maybe with a little bit more emphasis. Get Evosheld before you're exposed. So have a conversation with your doctor now about where in Yolo County you can go to get that injection. Secondly, get that fourth dose of an mRNA vaccine. So it's an additional dose plus a booster. So you should have a total of 4 doses if you're immunocompromised. And then wear the highest quality mask you can get your hands on when you're in indoor public spaces, and maybe even outdoor settings if you can't maintain distance. So that's going to be an N95, KN95, or KF94. And
Wonderful.
don't take it off indoors to eat.
Okay. Good additional suggestion and recommendation. Next question, and bear with me, it's a little bit longer question. What precautions do you recommend when visiting an elderly family member overnight for a weekend? We are middle-aged, fully vaccinated and boosted, and we have also been infected with COVID after being vaccinated and boosted. The elderly person we are visiting is fully vaccinated and boosted, but has not been infected. So I'll turn to you, Dr. Sisson, for this advice.
Yeah, I'd say everyone in this scenario has done everything they can in terms of vaccination to protect themselves. So that's wonderful. Plus, some of the individuals have hybrid immunity, which will offer additional protection. I think there's 2 layers of protection that could be added. One would be masking, but that may not be convenient based on the setting and the duration of the visit. I think another great option is pre-visit rapid antigen testing. With the wide availability now and the low cost, and also the ability to be reimbursed by your insurance company, these rapid antigen tests are essentially free. So I would recommend that everybody take a rapid antigen test right before they get together. And if that test is negative, they can feel comfortable proceeding with the visit, with those additional precautions in place and the fact that everybody is fully vaccinated and boosted.
Wonderful. Dr. Belafsky, anything you'd like to add?
Maybe for additional peace of mind, I would recommend the visiting couple to lay low in the 7 days prior to the visit to kind of curtail their own socializing so they could feel comfortable that they weren't inadvertently exposing themselves to someone with COVID.
Good. And Dr. Schorzman?
Great advice. The only other thing I would add is consider again getting tested afterwards, because if they did come up with a positive test, they'd want to communicate that to their elderly relative, I believe, so that that person could confer with their healthcare provider and be kind of on notice, so that they could be treated efficiently and effectively if something were to arise.
I must say, especially between the 3 of you, this is excellent advice being given to people from A to Z here on what can be done. So, Dr. Sisson, I think this question will be for you. I will phrase it exactly as they've written it. Why are we dropping mask mandates in schools when so many children cannot be vaccinated yet?
Yeah, so we're dropping mask mandates in K through 12 schools, where all children are eligible for vaccination. So there aren't children in a K through 12 school who are under the age of 5. So they're all eligible for vaccination. Many of them have elected, or their parents have elected, for them to not be vaccinated, but they are eligible for vaccination.
Wonderful, thank you. Next question, and I know we're getting closer to the end. So what suggestions do you have for resuming indoor group activities such as dancing for older vaccinated adults? And Dr. Belafsky, I'll turn to you first.
Oh, that's scary, right? Going into a group setting. Wow. We're talking about indoors, I assume?
Yes,
Mhm.
indoor group activities such as dancing.
Wow. I may need to defer to Dr. Sisson on this one. I was hoping there'd be a moment I could punt to you, but yeah, I think I will.
No, that's fine.
Happy
Dr.
to
Sisson.
answer. Yeah, I think it's partly going to depend on what the trend is in our case rate. I would say right now for an indoor group activity, while the case rate is 21, which is still high community transmission, I would recommend that everyone participating in that activity, strongly recommend that they would continue to wear a mask. I think you're going to see us go from a strong recommendation to a recommendation to simply optional on masking as the case rate decreases. But at this point, I would recommend that everybody mask. I'd also recommend that everyone would protect themselves with vaccination and being up to date on a booster dose. If there's particularly high risk individuals who are participating in this activity and it doesn't happen that frequently, it's another opportunity to use rapid antigen testing of the participants prior to the event to make sure nobody is asymptomatically positive. And so then I feel like with those multiple layers in place, you can feel pretty safe. The only additional thing I would recommend would be ventilation. So outdoors if possible, but we can also improve our indoor ventilation by maximizing the flow and the filtration of our HVAC systems. If that's not possible, we can put portable HEPA filters in indoor spaces. So all of those together would create a safer environment for indoor activities.
And so people are aware, those are the things that we've done on campus as well, with improved ventilation, our asymptomatic testing programs, masking requirements, and mandated vaccination and booster, as well as very often indoor events require a negative COVID test in the last 48 hours or 24 hours. I know I did enough of those last week that I got tested several times. And then I went ahead and had another test done before I saw my grandchildren yesterday. So I feel so fortunate to be at a university and the programs that we have in place that provide the ability to undertake all those precautionary measures. It's very fortunate. So this is our last question. And I think I'll give this to you, Dr. Sisson, and I apologize. You probably need a drink of water, but at least it is our last question. So what do you know about long COVID at this point in the pandemic?
Yeah, I will admit to not being an expert on long COVID. I think no one is truly an expert on long COVID. We're all still learning about it. We know that it happens. We're still trying to figure out what the risk factors are for somebody to develop long COVID and what may protect people from long COVID. But at this point, the best way to protect yourself against long COVID is to protect yourself against infection. And that is vaccination, masking, all the other safety layers that we talked about. The one thing we know is that you can't end up with long COVID if you never have COVID in the first place. But there's ongoing research into, again, the risk factors, and then also learning how to treat and manage patients who do have long COVID. And again, that is not my area of expertise, so I would defer to others.
Dr. Belafsky or Dr. Schorzman, either of you have a response that you'd like to add?
I would just call out the long COVID clinic at UC Davis Health as a great resource for anybody in the community who is suffering from symptoms and needs the help of some excellent providers. Great
suggestion. Thank you. Thank you all to our experts here. Gave excellent advice, and I think very practical advice that people can implement. So we're coming to the end of our time, and this video will remain posted on the UC Davis YouTube and Facebook pages for future viewing. Again, I want to thank our panelists for being here tonight and for all that they do on a daily basis to balance the many needs of our community. We are truly grateful for the partnership between Yolo County, the City of Davis, the Healthy Davis and Healthy Yolo Together programs, and UC Davis. This collaboration has shown how a university and community can work together in partnership to improve the health and well-being of the entire community. We also want to express our gratitude to our community for being so responsive in following guidelines and for being so compassionate throughout the pandemic. We also want to express our gratitude to our community for being so responsive and compassionate throughout the pandemic. Apologies, that was repetitive. I'm sure I speak for all our panelists here as well when I ask everyone to please continue to consider the health and safety of yourself and others as we combat the spread of this virus. Please note that vaccination is still the best pandemic measure against COVID-19 and is still highly recommended that you wear a mask when you are indoors or around others. And thankfully, in our community, we have the opportunity to be regularly tested for COVID-19 so we can reduce exposure to others. Good night. And thank you again for your questions, your time, and your continued commitment to keeping our community healthy. All the best.